Well, thank you so much for inviting me along. If you need to have a wee shugal or go and get a coffee, I'm very happy to wait. But otherwise, I think perhaps you're wanting the day to be over at some point. Yes, big thumbs up. So thank you so much for asking me along. Because I think it's a really important area that's often very neglected and also very badly studied, and does a huge disservice to people who have had traumatic brain injury. And thank you for that really moving testimony and that story that came, that was presented before. That was very moving. So I'm just going to maybe talk to you a little bit about sleep. I work here at the Royal Infirmary of Edinburgh, and I've been here for almost 20 years now. I trained in Australia, and I'm very passionate about sleep. And this week we're also running our Edinburgh sleep course that we started in 2006. So we've got lots of new professionals coming through from all walks of life. And I thought I would give you a bit of a rundown of what actually sleep is and what it entails, and then some of the therapies that have been tried in proper sort of randomized controlled trials. I'll try and make it as straightforward as possible. If I don't make something clear or you'd like to ask a question, don't hesitate to interrupt, okay? I'd be much happier if you did, if I haven't made something clear. So I'm going to start off with what is sleep. So I think we all think because we sleep that we don't need extra help with it, we don't need to talk to anyone about it, and that it is something that we should be able to deal with. And sleep is actually, we just don't go to bed and die for 8 hours a night or 6 hours a night or 10 hours a night. It's a really active process that is extremely important for our brains and for our health overall. And this is for people who like definitions. You may be one of those people. I kind of am, but it basically sort of gives us the best sort of definition that we have for sleep. And that is, it's a reversible behavioral state where we've kind of disengaged with the environment and we're quite unresponsive to the environment. Not completely unresponsive. There are some stages of sleep where we'll listen out and maybe wake up for our baby's cry. There are stages where our sleep is much lighter, like in dreaming sleep, and we're likely to awaken from that towards the end of the night. And while that's happening, our body's not just lying there like a dead jellyfish. We are actually, all the time, there are different changes to what's going on with our heart, with our breathing, with our muscles, with our immune system. And generally when we talk about sleep, we usually lie down to do that. We're not kind of horses or zebras, although they do lie down as well sometimes. So usually when you think of someone who's asleep, they've got their eyes closed, they're lying down, and they're not interacting with their environment. So I hope I'm not, teaching you something that you all know, but sleep comes in 2 different states that cycle over 90 to 120 minutes during the night for the duration of the night. And we've got what we call non-REM sleep, so that's non-rapid eye movement sleep, and then REM or rapid eye movement sleep. And they alternate with each other through the different stages over the course of the night. And if you really want to have a shorthand for that, in rapid eye movement sleep, our brain is dreaming, those crazy sort of B-grade horror movies or lovely things, or all those sort of, we're dreaming in color, and we've got a little bit of a story, and that could be incorporating things from experiences we've had during the day, could involve people we know, people we don't know, in all sorts of weird situations. We also dream a bit in the very deep slow wave sleep, and however, if you tend to wake people up during that period, they're usually black and white dreams. They can often be quite scary, so that's where if you, for instance, have night terrors, you'll be seeing those spiders coming out of the wall or that weird shape coming out of the cupboard. We usually, as adults, go through into sleep through what we call non-REM. Okay, there's also a stage of sleep called N2, which is our gating sleep. So that's during that first period where we go, and we fall asleep. As we go into slightly deeper sleep, our brain starts to disconnect from our frontal cortex, where we make the decisions, ethical decisions, decisions about what we're going to do the next day, those sort of important thinking things that we do. And we start to gate out all the signals from the external environment. And this is important for us to get rid also of very negative affective experiences we have. So it helps us to disengage a really bad experience from the emotions related to it. And then we go into very deep sleep, where our brain starts to clean itself. And from 2013 onwards, we've known that we have a cleaning system in the brain which is most active during that stage of sleep. And it takes out all that amyloid and tau protein that build up to, increase injuries in the brain, are associated with Alzheimer's disease and dementia, etc. And that's why it's so important to have that stage of sleep too. And then we usually lighten up our sleep. We go into that dreaming sleep, which helps us to further process emotion and also lay down memory. So how do we investigate? So if you get sent to me in the department or referred to me, how do we measure sleep and investigate sleep disorders? So if you've never been to a sleep clinic, this is what it kind of looks like. So we could do a big sleep study called a polysomnogram, where you spend the night with us in one of our bedrooms. We don't spend the night in the bedroom with you, but we watch you doing this, watch you sleeping during the night. And you can see there's all these wires there, because what we do is we set you up like this. And although it seems a bit weird, you can see that we're measuring your breathing during the night, we're checking out your brain waves, your muscle tone, your body position, so all sorts of things are being checked out. Has anyone ever come and had a sleepover with us? Oh, great, excellent, good, so you know what I'm talking about. It's not that scary, is it? All right, and then when we get all those signals over the period of a person's sleep time, we put that on, we then process it using computers and special programs. Maybe you've been to our department, or you know of people who have been, who've got sleep disordered breathing or sleep apnea, and this is what's happened. They've gone home with just equipment to check out their breathing during the night. And that ties in with, people who have had all sorts of chronic health conditions, and also people with traumatic brain injury. So there are ways we can do studies that doesn't involve you coming in to have a night with us, and we can also do sleep studies at home. And this is kind of the output that I've been talking about. So at the very top here in these bold colours is what we call a sleep hypnogram, and this is just the different stages of sleep that I was describing to you before. So you've got that stage of sleep, the N2, the green bits, where our brain disengages our lived experience from the emotional content of that experience. We also see the deep sleep here. We also see the dreaming sleep above the line. So that's that sort of brownish red colour. Can everyone appreciate that? And it's sort of happening in cycles. And that's someone with a really good night's sleep. And this is the different types of hypnograms. These are people with reasonably preserved sleep. So can everyone kind of see it sort of cycles through different stages during the night? And all of these stages are based on different types of brainwaves. Don't worry if they just look like squiggly lines to you. It's just to demonstrate that I'm not making it up and that we score them according to the brainwaves. And this is the stage of sleep where the brain cleans itself and helps us to sort of start afresh in the morning. And it looks like large alpine mountain peaks. And you see that these nice blue bits are important for us to get us fresh for the morning or the day. And as we sleep, the older we get, the less of that blue sleep we have, and that starts to diminish. And we get a little bit of a reduction in the dreaming sleep as well. If you've ever watched a baby sleep, then you'll know they often move their eyes back and forth, and they often go into sleep with that dreaming sleep first, because they're building all those nerve cell networks and laying down memories. Their brain is growing the whole time. And the slow wave sleep that I showed you is also very important, not only for the brain cleaning, but also it's during that period we make growth hormone to help us grow as we're adolescents and children. It helps us to recover, for instance. Say if you go and run a marathon, it helps to reduce the inflammation in the body. We have a lot of different hormones being secreted during that period that helps us to repair all the bodily processes in much greater quantities than they do get released in wakefulness. So everyone who's ever read Matt Walker's book will probably be panicking, because he said if you don't get 8 hours a night, you will die a horrible and lonely death. That is not true. So everyone has different sleep requirements. Some of us need 6 hours a night and we feel perfectly refreshed. Some of us need up to 9 hours a night. That doesn't mean there's anything wrong with you. Albert Einstein needed 10 hours a night, and so that's absolutely no reflection. It very much depends on genetics, on lots of different factors that are controlling your circadian rhythm, etc. So you can see that on average, probably adults, somewhere between 7 and 8, that's an average. But as newborns, we need huge amounts of sleep. So you basically have like a little cat. That doesn't always hold true either. And then as we get older, we need less and less sleep time to get through all those cleaning functions, memory processing functions during sleep until we become adults. And here, that's this magical 7 hours of sleep. This is all done on very, very large population studies of up to 1 million participants. And you can see it's just an average. So about 7 to 8 hours a night is average, but you can see that there are people who do less, who sleep less and who sleep more. And there's always this saying that, you probably live longest and, if you're sleeping here, about 8 hours, but we don't know. In these studies, remember, we don't know anything about the people on this end, and we don't know anything about people on this end either. So they're really just looking at the actual sleep time. These are huge numbers of people, and you can see that these people might be suffering from conditions that may be, contributing towards their mortality, compared to the other end, again, where someone could be in chronic pain, they could be, very unwell, there could be reasons why they are sleeping for that long. But if you actually need that night, then that's what you do. So why do we sleep? I think I've already discussed that a little bit in my introduction. Basically, a good way to think about it is sleep is for the brain, by the brain. And with the discovery of these sort of self-cleaning channels in the brain in 2013, particularly, we demonstrated that through animal models. We know that sleep is essential to that huge role it plays in health. And so what happens if you're a bit sleep deprived? So sometimes we learn about a condition by looking at what happens if we take a good condition away, or if someone is challenged by something like sleep deprivation. So I'm sorry if this doesn't come up so well, but again, there are different parts of the brain involved in things like language. Your temporal lobe is there. This is your neocortex, your prefrontal cortex here, where we make judgments. We have the frontal lobe, lots of creative thinking going on there. and various parts of the brain all interacting to allow us to function within society. And basically what happens in sleep deprivation is we're not as likely to learn things or retain them so quickly. You know, your maths and logic, if you're sleep deprived, are a bit slower. You know, your frontal lobe, you may, you know, that's why, for instance, all the nuclear reactor accidents happened in the 20th century. These all happened during the early hours of the morning with people on night shift who were sleep deprived. And instead of getting the manual out or asking someone who knew something to do something better, you sort of get stuck in a pattern. So if you've ever had that experience where you keep trying the same thing over and over again, but it's still not working, but you just can't sort of think outside that box. That's the sort of thing I mean when, you know, we're sleep deprived. We tend to not think outside the box and think creatively. This isn't about writing a poem. This is just about problem solving creatively. And we're probably much less likely to be able to make good judgments. I know that when I'm sleep deprived, I often get a bit more, I always take things more personally. I also feel more teary. You know, I may not be as rational as I would like to be in my reaction to perhaps a very minor problem. And perhaps all of you have recognized that to some point. The other thing in terms of sleep and wakefulness, we've got two processes going on. So we've got sleep, and we know there's a lot of genetic regulation going on. And we've also got something called a circadian rhythm, which is a rhythm that is determined by body clocks. And that all sounds very sort of science fiction, but there are lots of little clocks within our cells that determine how we react to actual time. And it's very much associated with light in the first instance, because our master clock sits in a tiny gland at the base of our brain. That's the pineal gland here. And it's affected by light. So we've got cells at the back of the eye in the retina, which are affected by light stimulation. So if we have darkness, so this is about melatonin, the darkness hormone. So we have, if it becomes dark, these cells become stimulated, and then they send messages to the pineal gland. It's quite a complex system, but they go via sort of neurons in the neck up into the pineal gland, and that's switched on, and we start to produce the hormone of darkness, or melatonin. This tends to start making us feel sleepy. It helps us to stay asleep, and usually the peak melatonin surge for people who have a normal, sort of are adjusted to this 24-hour rhythm that we live in, is usually about 4 a.m. in the morning. So then it starts to drop off, and as we start to awaken, our cortisol hormone starts to rise so that we can get that boost to get out of bed. Otherwise, you kind of get out of bed and you sort of don't know what you're doing. So we're talking about not an extreme night owl or an extreme morning lark. We're talking about people like me who are permanently exhausted pigeons in the middle, okay? So that's what the darkness hormone does. It regulates this circadian rhythm. And we also have, so when the light goes on in the morning, or we get the sunlight in our eyes, even on rainy days like this, what that does, it inhibits, it stops those cells at the back of the eye in the retina from firing their messages towards the pineal gland, and that switches the melatonin off. So I hope that makes sense. So someone who has no eyes or who is blind and cannot perceive light will often get what we call a free running sort of rhythm. They don't know when day or night is, and if they don't sort of have a regulated environment, or we don't give them extra melatonin, just a tiny amount, they will often just feel sleepy and horrible at all the wrong different times of the day. They will feel like they're permanently jet lagged. So I hope that makes some sense. And then we've also got, so we've got this two-process model. So we combine the circadian rhythm that happens, and we call it circadian because it's around the length of a day. And the actual timing of Earth's axis, and that's why it explains, you know, the leap years we have to have, etc., every 4 years is about 24.17 hours. So some people think that explains, you know, that we might be from another planet because we're not exactly rotating in 24 hours, which is how we've you know, managed our society. So we run on a 24-hour clock. But some people, and this is genetically determined, run on a much faster clock. And there are people who run at a much slower clock. And so there's also a big genetic component to sort of staying within those 24 hours. So if that doesn't make sense, please ask me. Does it kind of make sense, maybe? Okay. And then we've got the problem, and then we've got sleep. So if you think about this like eating, the only thing that will take your hunger away is having a meal. So it's the same with sleep. The only thing that will take your sleepiness away is sleep. Does that make sense to most people? So you've got that going on a daily basis, and at the same time, you've got this pattern, this rhythm for you to be less sleepy and more sleepy during different parts of the day. So that's why we get that post-lunch dip, because that's where our circadian rhythm is at its lowest. It's starting to get ready for bed later on in those 24 hours. And clearly, the more tired and sleepy you are, the more likely you're going to have a nap at that period in time. So I hope that sort of maybe explains that sleep is incredibly complex. It's really just my attempt to sort of show you how complex it is, and that we've got two processes we need to think about, and the sleep process itself is very complex during the night. So I hope you're starting to agree with me that you know, it is a very complex set of issues. What about, I'm not going to go through this, but it's just to show you that there are different parts of the brain are active in different stages of non-REM and REM sleep. And we've already talked about the functions of this sleep. And especially that deep slow wave sleep is very important to reduce you know, the inflammation in the brain, and to help us clear the waste products, to prune the brain cells, help them to grow and maybe change in different directions. And the connections between the brain cells are also particularly affected during this period of sleep. And already dreaming sleep or REM sleep, we know it's to do with memory consolidation and also helping us to regulate our emotions. So this is just a picture here of the glymphatic system, which follows the brain, the veins in the brain. And as I said, we didn't really know about this until 2013. And just to show you a picture, this is from animal studies. So you can see this red here, and there's a bit of green around the veins. And this is the sort of like, it's like the lymphatic system in the body. It sort of flows with the veins, and during deep slow wave sleep, you can see how much more active it is than it is during wakefulness. So it's still occurring during wakefulness, but it's really during sleep, that deep sleep, that it comes alive. So I'm going to turn now to adults with traumatic brain injury. And I think you all know the statistics, so I don't need to tell you this, but TBI in adults is more frequent than HIV/AIDS, Parkinson's disease, multiple sclerosis, and breast cancer. And that's on international sort of epidemiological studies. So we know that roughly 10 million people every year will experience and suffer from a traumatic brain injury. And in civilian populations, so we're not talking about people in army, who work in the army, etc., the most common causes are falls, motor vehicle accidents, being hit by or against an object, or a physical attack. And we heard the eloquent testimony of father and son earlier this afternoon about the motor vehicle accident, falling off a bike, being knocked down. We also know from studies that traumatic brain injury has a 3.2 times higher, so almost 3 times higher risk of premature mortality compared to people who don't have a traumatic brain injury, which is matched for gender and age. So I'm sure you're all aware of that, but that's why it always astonishes me that there is so little research put into sleep in this area, and I'll sort of try and demonstrate that to you, and how difficult it is for you if you suffer from a traumatic brain injury, if you're a partner, carer, friend, spouse, how difficult it is for you, and also I guess in some ways for me, because when you're coming to someone like me or my medical colleagues for help, we have a very limited evidence base for treating people appropriately or as accurately as we could be. So I think you're all aware of the Glasgow Coma Scale, and we know that's how we sort of give a diagnosis to brain injury, and there are a number of factors that determine, and I won't go through these, how severe things are, but you all know that we can classify brain injury as mild, moderate, or severe. And clearly, brain injury often doesn't come alone, and there may be other injuries, like a fracture, there may be internal trauma, there may be a punctured lung or a bleeding artery. So what happens when someone has a traumatic brain injury? Well, in the first 2 years post-traumatic brain injury, and clearly I can't speak from lived experience, so I hope those of you who do have lived experience can maybe tell me if what I'm saying from the literature is correct or incorrect. But studies that have been done in people with TBI demonstrate they're more likely to suffer from a variety of very persistent physical, cognitive, emotional, behavioural impairments, certainly after the first 2 years of their injury. And if that's not treated, some of these symptoms can also continue to cause problems medically. And we heard from the young man before about the headache that he's learned to control, sleep disturbances, incredibly common, depression, anxiety, irritability, and these all feed into each other. And so if you think about it, if someone is sleep deprived and someone has a traumatic brain injury, some of those symptoms seem very similar to each other. So you can imagine that, having like sleep deprivation or poor sleep on top of a brain injury is going to make the symptoms even worse. And I think, you're all aware of these issues that can occur. So it's going to affect your interpersonal relationships. It's going to cause issues with perception. You'll have mood and feeling issues, and also memory and thinking disorders. And it's going to depend on where the injury is, and I think anyone with lived experience will understand that, and things will be different. So not one person with traumatic brain injury will be the same as another. But as I say, if you have sleep deprivation, it's going to make all these things a huge lot worse. So if you're not sleeping properly. So again, that's also because of ongoing inflammation in the brain. I won't go into this, but people who do research in the area have established a lot of the different inflammatory responses that go on. So what about, it's very common, we know that, and the vast majority of people will report insomnia, so an inability to initiate or maintain sleep, Lots of people with traumatic brain injury will have obstructive sleep apnea. So people whose upper airway closes off at night, their tongue rolls back. So, you know, those sort of symptoms, if you're hearing that at night, if you're snoring, if you're choking, if you're waking up, you really should come and see us. Post-traumatic sort of sleepiness, excessive sleepiness is also common. And then nightmares and narcolepsy, which is also a form of excessive daytime sleepiness. And I've sort of talked about this, and it's very, very common, and I think extremely under-addressed. It's not addressed, I think, particularly well. And the reason is that most people who practice think that they can just transport a treatment that I would use in someone without a brain injury and just plonk it onto someone who's had a brain injury. And that doesn't always work. And it's probably not appropriate. It's better than not trying anything, but it may not be the right treatment. And that's, I think, gone on for decades and decades. I think it's also important when we're treating sleep and sleep issues in people with TBI that we think about thinking and memory as outcomes, and that is often something we don't necessarily do that in someone we think is sort of reasonably okay. They're sleepy, they're a bit tired driving, you know, they're falling asleep at work. We treat their sleep apnea, for instance, if that's the cause, and we don't specifically and in detail measure or look at their memory and cognition. We do that in research studies, but not in day-to-day practice. And also, even though there's extremely limited evidence for giving people things like antihistamines, which I don't think we should be giving anyway as sedating medication regularly, or benzodiazepines. So we're talking about temazepam, zopiclone, zolpidem, you know, sleeping tablets. They may not be the right thing to give people with traumatic brain injury long term. They can be life-saving, they can be used. That's not the reason I'm saying we shouldn't use them, but I think we need to also look at different treatments that can be sustained in the long term. And so it's not just a reflex, oh, I'll just write you a prescription for a pill. So we did a paper reviewing all of this, which was published a couple of years ago now, and we looked at treatments that had actually been trialed. And considering that 10 million people have a brain injury every year, they're very small trials with like 20 people with different forms of brain injury as well. So it's not just like a trial of 20 people with severe head injury or 20 people with mild head injury. They're often all mixed up, and often we don't have a good control group. So it's quite difficult to sometimes draw conclusions. So things that have been tried are acupuncture, warm foot baths, a medication that's given through a drip called NAC, and also some of you may have come across hyperbaric oxygen therapy as well. So we often use that to treat divers with the bends, and none of those have really been particularly successful. Blue light therapy has been useful. So we talked about the melatonin before and the sleepiness hormone. So blue light, so white light, which has a lot of blue in it, in that spectrum will also stop the melatonin from being formed. So if you're going into some kind of rhythm where your melatonin is being secreted all over the place because maybe you've had an injury to that area or some of the connections are not working particularly well, then it could be useful to keep you awake. So insomnia, incredibly common. So we can, in terms of giving medication, there are two studies that have suggested melatonin as an extra, given as a pill at the same time every day, can be very useful to maintain sleep. But there's a really good non-pharmacological therapy, so cognitive behavioral therapy is very useful. That involves a 6 to 8 week program. Here in the UK it's 6 weeks, with a therapist on a weekly basis, just to try and get some behavioural adjustments, and also just trying to sort of work around distraction techniques if you're lying there at night awake in bed, and that can be very useful too. People who are excessively sleepy, so people who are really sleepy, falling asleep all the time after a head injury, there are some stimulant medications that we can use. And they're called modafinil or armodafinil, which is available in the States. Again, if you think of the millions of people who suffer from these problems, I mean, not everyone with a head injury will have a sleep problem, but the vast majority of people do. Very small studies, but they have been shown to be effective. So we've got a little bit of evidence there. And then when I was talking about that circadian rhythm, so these people who become very delayed, like your teenager who won't go to bed till 2 and then gets up at 11 every day, or the older person who sometimes falls asleep at just after dinner at 7 and then gets up at 4 in the morning. So these sort of disorders of going to bed at sort of the non-socially accepted times, they're very common as well in these conditions. And again, we know that treating them with like melatonin-like drugs is useful, but not particularly, sometimes with some stimulants and with antidepressants, but those trials aren't great, but we know we can use them. But blue light therapy is very important, so making sure we time the amount of light that that person has to the back of their eye during the day, making sure we, so if you're going to bed very late, you don't want lots of blue light to keep you awake, because that's stopping the melatonin bit from being produced. You want that, for instance, in the early hours of the morning, but if you're falling asleep by 4 or 5 in the afternoon, we want to, on the other hand, keep you awake so that you fall asleep at a time that is more suitable for your lifestyle and your family. And sleep apnea, so that's the commonest medical disorder in our community. So up to 7% of middle-aged adults, so say people between the ages of 30 and 65 or 60, suffer from sleep apnea, the throat collapsing during the night, opening again, and thereby waking yourself up all the time. We know that the best treatment for it is a little mask that sits over the nose or the nose and mouth. It's attached by a hose to a small air compressor that blows air into the back of the throat as you breathe in and out to splint it open. Takes away that sort of choking and that constant waking up during the night that you're actually not even aware of. And again, how many trials do you think there have been? 1. And it wasn't even particularly good. It was just one where people got telephoned to put their CPAP on every night. So absolutely unbelievable. And then there have been no proper randomized trials in people with lots of people who have restless legs. So has anyone ever had, if you've had it, it sort of feels like you've got horrible Coca-Cola or something fizzing around in your veins in your legs, and it often follows that circadian rhythm. It starts to get worse as we start to go towards evening and bedtime, and it's very common in the community. There are lots of potentially treatable causes of it, but again, it's never been looked at in people with TBI. And clearly, if you've had a lot of a traumatic event with the head injury as well, there will be other issues we need to deal with, and a lot of this hasn't even been looked at. So I've already talked about why that's the case. I think there's a lack of recognition. I think there's been a lag in education in health professionals who do otherwise an absolutely marvellous job with rehab or with acute care and intensive care, etc., with respect to the importance of sleep. And I think also that sometimes when you have a traumatic brain injury, that the sleep problems can be, sort of dynamic. They can be fluid. So you might start off with terrible problems falling asleep. Perhaps you've been disabled, you start to put on weight, You know, you don't exercise as much, you might feel depressed, you don't want to go out, and you put on weight, and then you develop an issue with some obstructive sleep apnea, because if we put on, you know, we've got fat pads on the, you know, in our muscles and inside our necks as well. So there are lots of issues. So things can fluctuate and also be quite dynamic. And again, I think we really need to sort of get together as a group of professionals to work together. And there are lots of reasons, not just the head injury itself, that can cause problems with sleep and wakefulness and circadian rhythm, but all the other consequences that go along with having a really severe, potentially life-changing, you know, problem. You know, this needs to be considered, because we've already, hopefully, I know this talk has been super short, but it's basically, hopefully I've demonstrated that there are lots of functions of sleep that we need to repair our body, to help us regulate our emotions, to reduce inflammation, to clean our brains, and help them to get better during the night. So how can we make things better? So I think it should be, so lots of different you know, societies have included sleep in their guidelines for looking after patients. Even the hypertension societies, we've got obstetricians and gynecologists in their guidelines for looking after people, ask them to consider sleep issues. People who look after patients with diabetes also have sleep issues in their guidelines, but sort of most recently in my searches I've not been able to find that in any proper neurorehabilitation or TBI treatment guidelines. So first of all, I think it's an issue of education. I think it's an issue for actually doing proper big trials, not just with 6 people and a bit of acupuncture. It should be in like hundreds of people or 100 people with, you know, you know, and I'm sure people are always happy to help. And I think that we also need to have a lot of interdisciplinary collaboration and awareness. And I think sometimes what happens in busy NHS services is that we all get a bit siloed. And instead of looking at as the patient as a whole, we go, well, I'm just here to talk about your heart. Go away, go back to your GP if you're having sleep problems. Or, I mean, I've you know, had breast cancer myself, so I know what it's kind of like sometimes. And I think there's a huge amount of opportunity for improving things for people with traumatic brain injury. So I'm going to finish there, and I'd like to thank you so much for your attention. And I hope we as professionals, health professionals, from mental health professionals, allied health professionals, those of you who work as carers, support people in the community, charities, can all get together in a bit more consistently and address the specific needs of sleep issues in people with traumatic brain injury. Thank you very much.